1. Okay, we should be live. Hi, everyone, and welcome to another session. Today, we are joined with Dr. Prompton, who is here to tell us more about prosthodontics. Dr. Prompton, the floor is yours.
Okay, great. Well, I'm excited for this presentation. I think it's going to show you a lot of stuff that we do in prosthodontics. Honestly, our specialty as a whole is pretty mysterious. I think a lot of people don't really understand what it is. And even for myself, it's a little hard to kind of define what it is. So I just need to show you some of the kind of things that we do. And once again, the stuff that we do is very varied. So unfortunately, I can't really show you a lot of what we do, but I'll show you some interesting things and hopefully it gets you kind of interested in learning more about it. So I'm going to get started here. Okay. So a little video here with my office.
But the importance of honest relationships with our patients remains the same. We are not in the dental business. We are in the people business. We are different from other offices because of our focus and dedication to open communication and quality care with our patients. From the moment you walk in through the front door until the moment you leave, we want you to feel like you're a part of our family.
We realize you may be nervous about your dental appointment, which is why we offer IV sedation. We're always focused on providing the most comfortable patient experience.
Here at Lux Smiles, your time is very important to us. We understand that you have busy schedules, and that's why we're ready to accommodate you with evening and weekend appointments. At Lux Smiles, we are dedicated to providing the highest quality care at surprisingly affordable prices. We are happy to accommodate you for a tour in our office and have you learn more about things we can do for you.
We take our dentistry very seriously, but we're also going to have fun doing it. Everyone deserves to smile, and to smile with confidence, and that's what we're most passionate about.
Dr. Prompton has made me feel so comfortable and confident here at Lux Smiles, and I will be returning every single time.
Our 3D imaging allows us to diagnose and treat our patients with the highest standard of care for dental implants. Quality is our focus because you deserve to not only receive the highest level of dental care, but you also deserve to know the process and to know exactly what to expect. We communicate directly with our premium labs to carefully design your future smiles because we are all unique and we all deserve a smile we're happy with. You're not coming here just for your dental needs. You're coming here to join our dental family.
We're looking forward to meeting you and welcoming you to our family.
Whether you call or text us, we always want you to feel welcome. We are here for you.
Okay, so I opened Lux Smiles about 8 months ago, and it was kind of in the middle of the pandemic, of course. So very interesting time to open a specialty clinic. And so, I mean, that's pretty much what I've been doing the last 8 months, is really focusing on the office and getting more patients in. But I wanted to show you the video just since this is supposed to be a shadowing experience and you don't really get to see the office, but that at least gives you an idea about it. So I'm going to talk about kind of what happened for me and why I became a prosthodontist eventually. And so early on in life, I grew up actually in Houston, Texas. And here's a picture of me when I was like 13 or 14. I actually went through kind of like a K-pop boy band phase where I dyed my hair and I wore like a gold chain. I don't do either of those things now. But I grew up actually with a mom she's a dentist also. And so a lot of my kind of the influences in my life came from her. And so after that, I went to college at University of Houston, and you can see the cougar in the background there on the left side and the cat on the right side. Cougar was the mascot, and the cat I got my fourth year of college because I knew I was going into dental school and I needed an animal that I could kind of take care of very easily. So I have 2 cats. That's one on the right there named Duke. In college, I was a biology major and a chemistry minor, so that's pretty standard, I would say. And by the way, this is the cat right here in the video. So I would say that I took kind of a traditional route to dentistry with biology and chemistry. But I did have some kind of more unique things in my resume, which I'll talk about in a little bit. I got into University of Texas School of Dentistry at Houston for dental school for my DDS degree. And you can see me there in the picture right there circled. And our class wore kind of a Smurf blue color. So that was our class color. But so the 4 years of dental school were very interesting for me. I actually didn't decide to do prosthodontics until like the last second, right before applications were due. I was originally going to do a 1-year residency as an AEGD, so like an advanced general dentistry degree. But I decided that I did want to learn a lot more complex cases, especially involving implants. And so I decided to do my prosthodontic training at UIC, University of Illinois at Chicago. It's a 3-year specialty program. only focused on prosthodontics. It was a very heavily surgical program, so I'm a surgically trained prosthodontist. And so we'll show some of those cases later on that involve surgery and the prosthetic side too. Okay. All right, so I'm gonna give you a little bit of like some random kind of things that I thought of that would maybe help you guys as pre-dental students. I know a lot of times people will talk about like the grades that you should be getting, the shadowing experiences, and kind of all the generic stuff that you've probably heard a million times. So I'm gonna talk about some things that hopefully you guys have not heard of yet, but hopefully it'll make sense after I talk about them. Plans 10 steps ahead. This is extremely important, not just for getting to dental school, but in dental school and after dental school as well. But your academic advisor is going to be very important for you. And I know a lot of you are probably pretty close to graduating, so maybe it doesn't quite apply, but I would highly recommend that every step in your life, you look for advisors, not just in college, but afterwards as well. People that can guide you and help you predict what's going to happen, because if they don't and you have to guess on your own, a lot of times you'll make mistakes that you could have prevented before. Free time is also something that isn't truly free at this stage in your life, unfortunately. Right now with COVID going on, there's a lot of free time that you probably don't know what to do with, but hopefully like some of the stuff in this presentation you'll kind of pick out and you'll find different ways to use for your free time now to be productive in the future. It doesn't mean you have to work or you have to do something you don't enjoy. What I want you to do is pick something that you enjoy doing that will also help you in the future too. So, and then we'll talk about how to stand out. I think that when people apply to dental school, a lot of times they're science majors and they have pretty similar GPAs. They have leadership positions, maybe they do research, but you know, in the end, these are all things that are relatively similar on applications. And so kind of finding a way to bring out your own personality makes a difference. So that's something to consider too. You don't want to ignore opportunities. Social media nowadays is extremely important. And I'll show you a little bit of mine later. It's slightly embarrassing, but I'm still going to show you. So make sure to be involved with social media, because even if you're not going to utilize it now, but just remember in the future, it can be very important for getting patients. You want to be a part of some sort of a community. It depends on what you enjoy doing, I would say. But when I was in college, I kind of chose the pre-dental society group, which I think everybody in this watching this presentation should be a part of. However, there's also other communities you can be a part of that really that involve things that you enjoy doing, and that would be something else that really gets you motivated to kind of have an additional, have your personality kind of stand out from other people. Social skills, I honestly in college, I wish I'd worked more on them, because I used to go to college and I would go straight home. Wasn't a lot of interacting with other people. I would study a lot, and you know, it's kind of just like a straight path. But you should also definitely consider that social skills will add up over time. It's something that you actually practice on. I don't know if you can see my cat, he's like jumping around. So sorry about that. But social skills really matter, because when you explain things to patients later on, when you talk to your employer, when you become your own boss, all these things involve socializing, and you have to know how to do it pretty well. So start early, the earlier the better. Definitely recommend that. You got to be proactive too. I know this kind of all blends together. It's kind of like a Venn diagram. But when you reach out to other people, you can easily do that nowadays, looking for advice. Once again, that's going to go back to the social media thing, and I'll show you that in a second here. Shadowing is important. You guys are already doing the right thing by doing this kind of watching these presentations. Online forums, so basically just gathering information from other people. That's kind of goes along with like reaching out to other people as well. And remember that just because you have another student sitting next to you, you know, metaphorically nowadays because everything's online, but remember that they're probably going to be, hopefully they're going to be doctors as well in the future, in the near future. And so remember to seek out their advice as well, because they're probably just as motivated as you are, and they probably have things to share with you that can help too. Okay, so I'm going to show you like an example of each of these, kind of from my own perspective on things. And so how to stand out. I actually did some stand-up comedy.
Just got infection, so that's the first thing that happened. A large family of squirrels moved into yellow alcoves.
And unfortunately, it doesn't really show like the punchline, but I just wanted to show you that there are different ways that you can really stand out with what you enjoy with. I was horrified about public speaking, but honestly, this was kind of a breakthrough thing, and now I love talking to groups. So It's another cat here. So, okay, so now social media example. Okay, all right. And once again, being proactive, I'm going to show you just how easy it is to actually be proactive nowadays. It's much easier than it was before. So messaging people on social media is super easy. It's free. They may not always respond, but a lot of times I would say people in the dental field would love to help you guys out. So always asking, don't be afraid about it, just do it. Oops, let's see what happened. I think my keynote crashed. 1 second here.
Yeah, no worries.
Okay. And we're right. So I'm going to move to the next slide. Can you see it, or did it exit?
It's still not showing.
Okay, let me share screen again here. Sorry about that, guys.
Okay, it's up.
Okay,
and
now you
no
got it, right?
worries. Yes.
Okay, here we go. Okay, so that's enough about advice, and I'm going to show you a little bit about what we actually do as prosthodontists. And I'm going to start with like what the on-paper definition is of what a prosthodontist is. So we're the dental specialist for restoring missing teeth and treating complex restorative cases with advanced needs. We have advanced training in dental implants, cosmetics, crowns, bridges, etc. We're specialists in diagnosing, planning, and treating complex cases. We work in collaboration with other specialists. Sorry, I kind of skipped past that, but so we work very closely with other specialists and other general dentists. So it's kind of a team effort when it comes to prosthodontics, which is great. So if you're interested in like something where you get to work with a team, then Prost is definitely something to consider. Okay, and everybody's always interested in like income. I'm going to give you some general numbers because it really is all over the place for general dent or for prosthodontics. I would say like general dentistry focused prosthodontists, like first year out, probably 130 to 200,000. It really depends on where you are in the country, and educational positions as well. If you're like first year out and you're focusing on like an implant clinic as a prosthodontist, somewhere around 230 to 300,000 plus. And then once you become experienced and you're at a specialty clinic, anywhere from like 400 to 600. And then as a practice owner, anywhere from $0, -$, up to like over $1 million. It's all over the place. I would say it's the same thing as any kind of practice ownership. It really just depends on management of the office and area that the office is located in, and of course, all the things in between. It's a lot of work. Okay, so what kind of complaints do patients usually present with for prosthodontists? I'll show you some of the cases that I've seen. So missing teeth, a lot of decay, aesthetic issues, of course, and decay and missing teeth and grinding and a lot of other things. I mean, we see everything. We see cases where there's no teeth, where there's almost no bone for even a denture, as you can see on the left side. We see cosmetic cases like the one on the right side. But what do these patients end up showing up with and saying? A lot of times we actually hear this: I want wider teeth. And if they come in looking like those pictures, of course, we can't just do that. So that's kind of out the window. But honestly, though, a lot of patients do want wider teeth, and prosthodontists do see patients like this. So we do whitening also. So we do a lot of the complex stuff, but we also do cosmetic stuff too. Okay, so it kind of breaks down into missing teeth, single teeth, multiple teeth, or a full set of all teeth missing. And a lot of times these are kind of split up into two groups: cosmetic needs and functional needs. However, often you can't really categorize a case as just purely cosmetic or purely functional. It's usually both combined together, because if we just make somebody look nice and we don't consider the functionality, the niceness doesn't last that long. So we have to consider both. Okay, so I'm going to talk about, there's really like kind of three categories I wanted to talk about, and it was kind of split into cosmetic, implant dentistry. So I'm going to show you in a second here. Implant cosmetics, and also full mouth reconstruction. And each of these I'm going to show you some terminology first, and then we'll go into the cases after. And then from there, I was going to show you a little bit of bonus material. However, because full mouth reconstruction is so comprehensive, I unfortunately couldn't include a case just because of the time restraints. And also, the kind of fun bonus stuff I was going to show, but we'll still keep it really fun. It's going to be very interesting. So when it comes to terminology in prosthodontics, here's the glossary of prosthodontic terms. It is well over 100 pages. So obviously I had to choose and pick just a few out for you guys. And this is me just going to scroll through it. But as that's going through, let me talk about the few kind of terms I'm going to use here so you guys have an idea about what's going on. So anytime I say restoration, it just means anything that replaces missing tooth structure. Anytime I say the term interior, it means in front of or forward, but it can also refer to the front teeth, which are the incisors and the canines. And then posterior is the opposite of anterior, it means behind or backwards, or it refers to the back teeth, which are the premolars and molars. And then bonding is a really important thing for cosmetic dentistry, and it refers to a technique involving the adhesion of two different materials. Okay, so, and also when it comes to terminology for cosmetic stuff, there's a lot of different restoration types, and they're kind of split into two main groups. We have indirect or direct. Indirect means that we're making, for the most part, the prosthetic or the veneer or the restoration outside of the mouth, usually in a lab. Direct means it's usually done inside of the mouth. So indirect restorations can be things like veneers, crowns, bridges, inlays, onlays. And direct restorations tend to be fillings, such as amalgams, composites, or even chairside veneers. So all of that's mostly done in the mouth, as opposed to like indirect, where we send it to the lab. There's a lot of different crown materials. I'll talk about the four primary ones. We have lithium disilicate on the left. That is also called Emax. It's usually like if a lab, or actually if an office has their own milling machine in their office, that's usually what material they're making them from. So you can see the block on the bottom left side is this Emax CAD. They come in these like they look like Legos. You put them into the machine, it actually mills it out based on a digital design of the tooth. Then we have more of a traditional material there in the blue, porcelain piece of metal, which is also known as PFM. There's a metal coping that's underneath, and then you have porcelain stacked on top. You can see the bottom picture, that's just the metal coping, and then porcelain gets layered on top of that. And then we have zirconia, which comes in three different, well, it comes in more variations than just the 3Y, 4Y, and 5Y, but it's a very hard ceramic material. It's actually 10 times harder than titanium. And the Y in the 3Y, 4Y, and 5Y stands for yttrium, which actually stabilizes the zirconia in a cubic state so that it doesn't, cubic is actually like the strongest lattice form of this material. And if we didn't put yttrium into the material, it would actually be unstable unless we heated it up to like 2300 degrees. So we have to stabilize it at room temperature, and that's what yttrium is for. The different variations will change the translucency, but the more translucent it is, the weaker the material becomes. And those are also milled out a lot of times too, as you can see in the bottom circle picture there. And then last material that I'm going to talk about is gold, and that's kind of a tested and tried material in dentistry. It lasts a long time. The only thing is that a lot of people nowadays don't want things that don't look like teeth, and so gold is a little bit different, but still some patients want it. AU, I'm guessing that's pretty fresh for you guys in science majors. So, okay, so we'll talk about cosmetic. We'll show a couple cases for that. This is a patient that really just wanted her front teeth to look nice, and the first time I met her, it was very difficult to get her to kind of open up to me, literally. So she wouldn't show her teeth. This is also known as a guarded smile. A lot of times when patients are embarrassed about their front teeth, they'll cover their mouth up when they smile. They'll smile like the patient showing here in this picture. So it's called a guarded smile. And she really didn't want to show me her teeth. And so now she decided to show her teeth, and you can see probably why she was a little embarrassed. So she's missing a tooth, and she's got a lot of other cosmetic needs. The incisal edge position, you can see that line is kind of all over the place. So the teeth are not even. She has a lot of discoloration in the teeth in yellow. She has a crown that's a completely different color, and it's about 1.5 millimeters longer than the adjacent teeth. She has a fractured root tip that's still in the bone there. The crown is broken off, and she had a root canal. And then obviously the missing tooth on top. So in order to correct this, we started with initial shade selection to see where she started with. We went into bleaching, so she actually did some whitening take-home version for a couple weeks. Came back in and we did the crown preparations for the teeth, and so this is where we have to reduce the tooth structure 360 degrees all the way around to provide enough space for the ceramic material that's going to go on top. And you can see also that in the white little outline there that I extracted the tooth atraumatically so we didn't lose any bone. And so that's healing up really well there. Then we do something called a stump shade, which basically means we're taking a shade selection, the current color of the teeth underneath. So as we reduce the teeth, if we're going to put a material on top that's translucent, the color underneath the teeth can possibly show through the material. So the color underneath, the technician needs to know what the color is so that if you have one tooth that's darker than the other ones, he can accommodate for that in the crown buildup. And this is the stump shade selection here. And then we have different shade tabs for the color that we actually want the crowns to be. So the shade that we selected here is the 2R on the VitaPan 3D Master. There's a ton of different tooth guides for shade selection. And so this is just one of many. Okay. So for something that I like to do, usually for cosmetic cases, that if we're going to do crowns, we do something called a bisque bake try-in, where we try in the actual real crowns, but before they've been final glazed, and they're kind of in this like, what is the word I'm looking for? They're like in a matte finish before they get the glaze and the final colors and everything else, because they're easily adjustable at this point. They're way weaker than they are when they're final glazed. So we can also evaluate the overall cosmetics. You can see that the gum line is a little uneven across the teeth, but the patient didn't want to go through any kind of corrective gum surgery for this. And there's a little black triangle right there in the middle. And that's what I was kind of pointing out with that guy on the skis. But that was something that we're initially concerned about in the temporary phase. But a lot of times when the final crowns go in, the material is a lot more respective of the gum tissue's biologic health. And the gum tissue will actually grow back in. So now delivery day, we actually put the crowns in, cemented them all. And you can see that little triangle still there. However, about 2 weeks after, we brought the patient back in for a follow-up, and the gum tissue's grown in very well there. So you can see that the overall case, what we ended up doing were 3 crowns that were individual. And then on the other side here in the yellow, we did a bridge, which had 2 abutments. That means like the end points for the bridge, they're real teeth underneath. And you have a missing tooth in the middle called a pontic. So that's what we did for this case. Okay, a before and after, and then unfortunately, like my before picture from the side was not good at all, and then here's after. So, and now I'm going to go into a second case, a lot more simpler, is a lot more simple, but sometimes simple cases can be even more complex because you're trying to match. For instance, this one case here, we're doing just one veneer, so one restoration to close up a space between her central and her lateral incisor. And when we're trying to match the color of those teeth, it's very important that we get a good shade selection. This case we did completely digitally, so there was no impression material at all. And so we use a digital scanner to actually scan the teeth, and we get a bite. And so all that's taken care of, I do a scan of the preparation like you see on the left, and then a scan of the temporary on the right. This was all done in a single day. So the provisional is another fancy term for temporary, but in prosthodontics, we don't like to say the word temporary because we actually use our temporaries for the lab to communicate with them so that we can show them how we want the tooth to look and communicate with them better, because we want the final one to be based on our temporary or the provisional. If you let the lab dictate the shape and the size and the functionality, then sometimes it's not quite there. So I always like to have I like to be happy with my temporaries before I send them out. And then this is the same day, once again, the temporary veneer. We still haven't cemented the final case. I'm still waiting for the patient to come back in soon. So the temporary is right here. The color actually matched almost perfectly, but you actually get dehydration of the adjacent teeth when the patient's open for like more than an hour. So that as the teeth dehydrate, they become lighter in color. And then we have the final veneer. You can see actually from the digital format, they actually print out the models. So you can see those on the left side, and then the veneers on the right side. So that's actually just a single veneer. I just wanted to show like both sides of it. That little gray thing that is underneath is called a die. And that's basically what they use to check to make sure that the veneer is completely sealed with the preparation. That material that we use for that veneer case is Emax, and that's the lithium disilicate, and it's the same material that we used for the other case before. So it's actually a very popular material, and there's 2 ways to make that material. There's a way where they mill it out of those Lego blocks, and then there's another way that they can actually do, they stack it. Basically, they kind of compress the material as a powder, and it becomes even harder than the milled version. So a lot of times I do prefer to go with Emax pressed rather than Emax milled, but it's a personal, kind of my own opinion about it, but that's what I prefer to go with. Okay, so we're done with the cosmetic stuff. Let's go into implant and surgery. And so I'm going to talk about some terminology, kind of basic stuff about implants. Maybe you guys know about this, maybe not, but what is a dental implant? It's a biocompatible device used as the bony anchor to support or retain dental prosthetics. These implants are typically made of a grade 5 titanium alloy. It's very hard, but it's also biocompatible. It actually will regenerate the outer oxidized surface so that if basically it gets any kind of wear on the outside, it reforms very quickly with an oxidized layer. So when it comes to corrosion and when it comes to like, corrosion essentially, it's almost impossible for it to get, as long as there's access from oxygen at the surface, which actually can creep down the gum tissue. So oxidization is a very important thing for biocompatibility, and these materials were actually originally focused around like hip replacements. So it's a very similar material to what they use there. They can also be made out of zirconia and also zirconia alloys mixed with titanium, but that's a whole other like presentation to talk about. So dental abutments, they are the little pieces that go into the implants, and they kind of function as like, if you saw the crown preparations earlier, that's kind of what they function as. It's like a tooth that's been shaved down essentially. So that's inserted into the implant, and it joins the implant to the dental prosthetics. And then we have an abutment screw, which actually will go through the abutment, and it screws the abutment into the implant. And so I'm going to show you kind of how the alignment goes. It looks like this, and then the screw goes inside, and it fastens the abutment to the implant. And then the crowns are made, and they go on top, and that's what the crown looks like on top. So you have to imagine that implant is actually completely submerged within the bone. Sorry, I need to grab some water, but my cats drank my water. I'll be right back.
No worries.
All right. It's a very casual little presentation, right? So one thing, I'm gonna make sure my cats don't get to this one. All right, I'm good. Okay. So you have to imagine that that gray piece, which is the titanium implant, is actually completely submerged in the bone. That's usually what how implants are placed nowadays. The abutment, kind of that shiny portion underneath the crown on the right side there, that's where the gum tissue kind of surrounds it. And so the only portion that you really see in the mouth is the white part, which is the tooth colored material, which is the crown. So I'm going to show you also kind of break down what the different kind of implant restorations are. We have implant crowns, which are actually a single crown for a single implant. So I'm kind of showing you a model version of that. So you can see where the implant is kind of submerged in the stone there. It represents the location of the implant. You have the abutment right above that, and then you have the crown that goes on top of that. And then we get into a little more complex kind of situations. So a fixed complete denture is an implant retained bridge, usually on 4 to 6 implants. It's also known as all on X, with X representing how many implants there are. The most common version of this is all on 4. So if you have heard that term before, that's what this is. 4 implants, usually the back implants are angled 30 degrees, and that's to accommodate for the maxillary sinuses. The further back we get the implants, the more teeth we can have for the patient. So we angle them to avoid the sinus wall. So they're angled kind of like this. And so the part that connects to the abutment, because we angle it from here to like that, goes further back, and we're able to add an additional tooth to the prosthetic. And the 2 front implants are usually very straight. The abutments are made to correct the angulation, so they end up being pretty parallel for most of the cases. So the back implants get like a 30-degree abutment, which uprights them, and it makes them parallel with the two in the front. Okay. And then we have like the most complex kind of situation, which is called implant crown and bridge. These usually involve just 6 to 8 implants for like the top, 6 to 8 implants for the bottom. If you remember what the image was just before this, you'll notice like that prosthetic. Actually, I'm going to show it. I'm going to go back. This prosthetic is very thick and it has the pink gum tissue connected to the bridge. That's for a fixed complete denture. When we go into implant crown and bridge, I'll show you, you'll see the result of this in a few slides here. There's no pink at all. It's just representing the teeth that are going to come out. So the pink part in this kind of prosthetic is the natural gum tissue, and the implants are not as deep as with an all-in-4 or the fixed complete denture. This is probably the most expensive like procedure prosthodontists will do. It's a very complex, time-intensive, a lot of brain power has to go into it because of all the planning. So it's a pretty complex case, and this case in particular it involved 3 different implant systems, and I'll talk to you about how that happened. So, and then another really important thing, the last term I'm going to talk about is cone beam computed topography, which is CBCT. And you can see in the background of this image, there's like a giant white thing labeled CAVO OP3D. That's CBCT. So it's not just something for like panoramic X-ray for like a 2D image. This is made for 3D image gathering. So we can actually plan the location of the implants before we start the case. So I'm going to show you what that looks like here. So Thursday, sorry. So, okay, so before we place the implants, I like to plan the prosthetics first. So the thing that you see in green is actually like a removable temporary partial that we just use to scan because we were happy with the location of the teeth. And then once we're happy with the teeth, we can put these little tiny stickers that have these little bumps on them. So if you see the green, those like little lumpy things on the outside, those are actually called fiducial markers, and they show up in the X-ray so that we can actually align the, and then we scan like the temporary partial on the side by itself, and we can actually line these up in the scan. So we can actually plan the location of the implants based on the future teeth before we touch the patient at all. So we always design our surgeries based on how we want the final results to be. And I'll show you what kind of more like a close-up of the actual planning for the implants. We choose the size of the implants, the depth of the implants, and everything based around the future teeth. So we're making sure that yellow beam that's shooting upward is actually going through the central part of the teeth so that the hole that comes through can actually be oriented in the right direction. Okay, so I do have surgical photos coming up, and some of you are probably excited about that, and maybe some of you would like to kind of like close your eyes for a little bit. I'll tell you when the surgical slides are done. I think it's just one slide for now. And so if you're scared like my cat is when he goes to the vet, then you may want to just like look away for a little bit, but you can listen to me. I'm not gonna like describe anything in a really like gross way or anything, I promise. So, okay, I'm gonna start now. I already gave you the warning, here we go. Okay, so I'm going to show you a case that involves the top and bottom jaws together. And so the mandible, the lower jaw, is implant crown and bridge. And you can see in this picture that that is the mandible, the mandibular ridge. So there's no teeth left, it's just the bone. And there really wasn't a ton of bone there, but we had pre-planned the case for the implants. And so we have our surgical guide on the bottom left there. That will help to orient us completely based on the plan that we did digitally. So even though there's nothing there, we know exactly where the implants are going to go before the teeth go in. This is after the implants have been placed. We did 6 implants for 3 different bridges. So basically starting from the left of the image, if you go from the back implant to the one in front of it, there's like a bridge of 3 teeth. In the front there, a bridge of 6 teeth. And then on the right side, a bridge of another 3 teeth. In the bottom right side, you can see that's it's called a provisional shell. Basically, those teeth are milled out by a lab, and we have a little section that goes like little extra stuff that's actually used to kind of put it into place so that when we attach it to the implants, it's oriented in the right direction. And it's actually hollow on the inside, so we don't have to grind a ton of material on. So when we put it into the mouth, this is not connected yet. You can see it's not even seated completely. I was just kind of rushing through the photos. But these are the milled provisional shells, so the patient can leave the same day with teeth. That's the exact same prosthetic right there. This image on the top right, you can see the same milled provisional shells have already been connected to the implants. Those are actually completely screwed in. It's all one solid piece. They're not going anywhere. So even the day of the surgery, we can give the teeth to the patient. That clear looking prosthetic above is not going to be used. The patient's not going to take that home. It's used as a surgical stent for an all-on-4 prosthetic. For all-on-4s, a lot of times the location of the implants is hard to plan beforehand, especially when there's teeth involved, because we need to find the best bone available for the implants to go in really strong. So a lot of times it's done visually with some guides, like using the surgical stent to know where the implants should go. But then we look for the thickest bone and the strongest bone. So that's why it's not truly guided. It's not a surgical guide, it's a surgical stent instead. And you can see the shells on the bottom there. And then an immediate denture will actually go into the top and actually gets attached to the implants the same day. You'll see a different case that shows that. Unfortunately, I didn't have the photos for this case specifically. So now from there, the implants will heal for about 3 to 4 months. And then we take impressions. And this is going to show you kind of an issue we face in implant dentistry, where the second we take out the temporaries from the bottom or the provisionals, we take them out and the gum tissue will actually collapse before we can get our impression material in. And if the gum tissue collapses, our final prosthetics or our final bridges will not look the same as the temporaries did. So this is kind of showing the process of how we capture all that. First, we do take an impression of the implants, even though it does collapse. So you can see this top left image. We pour up that initial impression. That blue stuff is actually like rubbery material that simulates the gums. And then we take that gum tissue off, like the top right image. Then we take the patient's actual provisionals, and then we put that onto the cast, and we actually screw it in, like the bottom left side. And then we inject more of that same blue stuff, which is also called soft tissue moulage. And we inject it underneath, and it's going to capture the contours of those temporaries. And now you can see the top left image looks very different from that initial impression. It's because the gum tissue now is not collapsed, because it's actually the shape of the temporaries. And that's what we want the finals to look like, is like our provisionals. So that red stuff on the right side is like a really strong acrylic material that doesn't shrink too much. And we segment that into the bridges that we have planned for the final set of teeth. And then we put that all into the patient's mouth and screw them in. And we take our impression with that. So those are all impression copings, which means like they're like little pieces that attach to the implants, and they show us the orientation of the implants for the impression. Those impression copings and the red stuff, it all stays in the impression. And then we attach these little tiny silver pieces that you see in the photo here to each of those implant attachments. And those are called analogs. And those get poured up in stone. And those act as like the synthetic implants that are kind of showing us the orientation, so that the lab can actually make this very accurately. From there, they take that model, and based on our temporaries, they'll make custom abutments, which are, we talked about those abutments earlier, which are like, it's what the crowns go on top of. You can actually anodize those to be gold or pink or different material, different colors. Gold is a really popular one for teeth in the front, for implants in the front when the gum tissue is really thin, because silver will show through a lot of times if the gum tissue is not more than 2 millimeters thick. So for this case, I was like extra fancy, and I went with gold even in the back. I honestly would probably never do this again, but it was like really cool Instagram photos, so I decided to do that. But all right, follow me on Instagram if you want to, by the way. So, okay, so this is that case that I told you about that had like, it's implant crown and bridge. So there's no fake pink tissue. This is all natural tissue. This is the case that had 3 different implant systems. And the way that happened, and you guys will probably encounter this even more than I do, is that patients nowadays, implants are so popular that they'll come in and they'll have a tooth that needs to come out. And so tooth will come out that acted, and the patient will get an implant the same day or like shortly after that. And then like 3 months from now, another tooth needs to come out. They'll place another implant there. 3 months later, another one. And it keeps going on their entire life. And they end up with like a ton of different implants. And if they moved out of state and they went to another provider, then they're getting another implant system. So they end up with a ton of implants. And it gets pretty complex when it comes to like restoring them. So that patient before we started they had like implants from like 15 years ago, 10 years ago, 5 years ago. They're just kind of all over the place. So we actually redid everything. We actually took out some natural teeth that were left. We placed new implants in where we needed to, and there were some implants that we had to take out. So pretty interesting case. So once again, that's all implants on top, all implants on the bottom. And I'm going now into, let's see what time is it? Okay, yeah, I'm going into the final set of surgical photos. There's more surgical photos for this set, and I forgot to let you guys know that the other surgical photo was done. So if you want to look at this slide, you can, and then more surgical photos right after. So I'm going to continue now. Here we go, surgical photos. So when it comes to implant entry, of course, we see ailing and failing implants. Implants have very high success rates, 96 to 98% after 5 years, and they can actually be about 94% after 10 years. Studies show somewhere around those numbers, but it doesn't mean they can't fail. So this case here is an all-in-5 patient, and this is the upper jaw. So you can see here, just to orient you, the anterior means like towards the front of the face, and the red area is pointing back or towards the back of the throat. Those, the gum tissue you can see is very like dark and red and kind of maroon color, which means there's a lot of localized inflammation. And so when we took x-rays, I already knew what was going to happen underneath. We had called in the oral surgeon for this case because it involved a special kind of implant that you're going to see in a second here. But you can see those 2 back implants. The posterior implants have lost almost all the bone around them. You can see the macro threads, which are like the bigger threads, the spirals around them. You can see the micro threads at the top or like closer to the bottom of the photo. And then you can see the abutments that are on top of that. And that's kind of the piece that's kind of like angled slightly here. So in a case like this, regrowing bone around those implants is usually not recommended. And a lot of times the implants will be taken out. So the 2 back implants were removed. And we went with something called zygomatic implant placement, which is a cheekbone implant. So it's kind of a cool case. And you can see in this picture here, we have the lateral wall of the maxillary sinus. So that's like this area right here. Maxillary sinuses are located here. They're just air spaces. And so usually when you get seasonal allergies, you'll feel like pressure built up in this area. That's the maxillary sinus. In the maxillary sinus, you have a lining. It's actually specifically for maxillary sinuses. They're called Schneiderian membranes. And that's kind of like a rubbery material that lines the outside or the inner portion of your sinus. And then everything else on the inside is usually just air. So we expose the Schneiderian membrane and we kind of lift it up to make sure we don't pierce through it. And then we have a zygomatic implant that goes in. And I'll show you what this is exactly because they're not super common, but they are needed for some cases where there's not enough bone in the rest of the maxilla. So this is a zygomatic implant in the back here. By the way, if you guys are not watching, this is a non-surgical slide. So if you want to watch this, feel free to do that. So zygomatic implants are very long. They're much longer than regular implants. They're usually between like 35 to 60 millimeters long. A regular implant is usually between 7.5 to 18. So they're much, much longer. They come in different variations. In the photo on the left side, you can see there's like a smooth portion in the middle. It's because sometimes these implants can actually be placed directly through the sinus itself. And when you have a smooth inner portion that goes through the sinus, it's less likely to build up kind of gunk around it. So typically these zygomatic implants have the threads all the way through them though. So you can see here on the left image, the diagram, they actually go into the cheekbones. So the main anchor point is the cheekbone right up here. And then they come in at an angle out through the mouth, and they do have an anchor point in the maxilla, kind of in the bottom of that image. You can see it is in the maxilla, a little bit below the sinus, but the primary stability does come from the cheekbone. So some patients actually don't have cheekbones either. They just have like a little a little tiny sliver of bone for the cheekbone, and we can't even do zygomatic implants for them. And then at that point, we have to look for very creative options. So, okay, so those are zygomatic implants. We plan 2 for this patient. So this is okay, back to surgical slides, I almost forgot. So a buccal fat pad, if you guys didn't know, your cheeks are not just cute and fluffy for no reason. They actually have a chunk of fat in them. Everybody has it. And so that's called the buccal fat pad. And so on the right side, that yellow egg yolk looking thing is fat, and that's the buccal fat pad. So that's within the cheek. And we can actually use that to cover up areas that are exposed for zygomatic implants. And it's very vascular and it has a lot of growth potential in it. So it can actually help to regrow the bone that's missing around that sinus. So you can actually use that buccal fat pad and advance it over the zygomatic implants because it's very highly vascular. You can actually suture it into place underneath the gums. And then the suture gets covered up and it gets, the gum tissue gets advanced over it and the patient doesn't even feel it after that. You have to be very careful with the buccal fat pad so it doesn't atrophy or die out, because then the patients can actually get kind of a sunken appearance because the fat is completely gone in their cheeks. So the image on the right is showing the other side. Once again, this patient was getting 2 zygomatic implants. And you can see actually the implant already has kind of an angulation correction because these implants are always placed at an angle. And so these implants kind of come in, I think it's like a 30-degree or 60-degree or 45-degree correction. So based on our planning, we decide which kind of implants are placed for that. Okay. Okay, I'm good. So allograft is a bone graft material that's actually made from, it's harvested from human cadaver bone. And then it's stripped of all the proteins, all the enzymes, everything that made it who that person originally was. And all that's left is like a cellular matrix of bone. It comes usually dried, and it will need to be rehydrated with sterile saline. And it kind of forms like little mushy material. It's not super mushy, but it starts off kind of like a granular salt material. And it gets packed into areas that we need the bone for. So all those defects that we had when we took those implants out were filled in with that bone graft material, which is, once again, it's called allograft. There's other materials out there. There's xenograft. There's you can use cow bone, horse bone. You can use plastic materials, a lot of synthetic stuff. I would say probably the most common one, though, is allograft. You can also use the patient's own native bone, but a lot of times you have to harvest it from, it depends on how much you need, but you have to harvest it sometimes from the back of the mandible, which can be very painful. It's another surgical site, so we try to avoid that when possible. Sutures are placed. Everything gets kind of sealed up as well as it can. It's a pretty big surgery, so the suturing can be pretty difficult a lot of times. And you can see on the right side, that's actually the temporary prosthetic, the one that the patient had when she walked in. But of course, those 2 implants in the back that were connected to it are missing now, and we have 2 new ones. So you can see that purple material there is actually, it's called bite registration material. I just use that to give like an imprint on the underside of that to show where the new implants are to the lab technician. And then I will drill holes out where those 2 imprints are, and we'll connect something called temporary cylinders to those back implants. So on this image on the left side, these areas that are yellow are actually where the new implants are. So those are the zygomatic implant locations, which are reconnected in the mouth. And you can see in the top right image, that shows like the undersurface, how they're reconnected. And those 2 holes in front of them are the 2 implants that were already removed. So those holes will just get sealed up completely. And unfortunately, I didn't take another picture of this in the mouth. So however, it just looks like teeth. I mean, all-in-fours typically look very nice. We have to be very careful about showing that junction between the prosthetic and the gum tissue. So a lot of times we have to take very careful measurements of how high patients will smile. If they smile like normal, or here, like normal, then we don't have to reduce as much bone and we don't have as much requirements for the bone. However, if a patient has like a very high smile line, so their lip is like hyperactive and goes up really high, then of course they may show the junction and they may not be a candidate for the all-in-4 or all-in-X procedure unless they have so much extra bone that we can actually reduce it up to the point where the prosthetic will hide, the junction hides. So that's the entire presentation. I think I'm on time here. Those are the 2 Instagrams I have, my personal one and also the Lux Smiles dentistry page. We have pretty interesting stuff on both of those, so feel free to follow. I would highly recommend that if you guys have any questions after the Q&A section, to always message me anytime you guys want to. I'm more than willing to like help you guys out in any way. And I guess you could email me, but honestly, I'm better at like responding to Instagram. So that's it.
Thank you so much, Dr. Prompton. Ewan should be coming in to ask the questions that were asked in the chat.
Sure, great.
We have a few questions. So I guess the first one is, can you talk more about your pre-dental application experience, such as the schools you applied to, why you chose UTSD Houston?
Sure. So my application process, honestly, the things, it's been a long time. I graduated college back in 2012. Is that right? No. Yeah, that's right. Oh gosh, 2012. So yeah, it's been a while. So the application process, like I would highly recommend that you apply as early as possible. Early applications do matter. At least when I applied, I think it gave a decent, like favorable response if you could apply early. If not, it's not the end of the world and it's not a requirement, but I would definitely recommend that. When I applied, something that was a little unique on my application was University of Houston had kind of a healthcare professional like committee that if you applied to it, it was like you're applying to like medical school or dental school. You sent them all the same stuff. And it was a bunch of faculty members. They would review everything on your application. They would give you a score of 1 to 10, what they recommended to whatever school you're applying to. And it was like a really amazing like letter of recommendation. So if your school has anything like that, definitely try to do that. It's not even a requirement to send it in if they give you a bad score. So nothing to lose. Like they gave me a really good score, so I sent it in. The application process though, like writing the essay and everything, honestly, I wish I could help you guys out. That's probably the one thing I can't really remember too well is like how my essay was. I talked about like, I was a professional laser tag player for like 4 years. And that was like my hand-eye coordination like thing. And so that was very unique and interesting. And I felt like I juggled also, which is like, I don't know if I would put that again if I had to redo it, but like you should definitely talk about personal stuff that makes you interesting and like seem like a real person. You don't want to seem like a robot. Like don't put just your like objective stuff, like your numbers and your like, oh, I did like 400 hours of community service and all that. Like that's part of the numbers that you fill out already. You want to stick to what makes you unique. And then I chose UT Houston because I actually grew up in Houston. It was 30 minutes away. It was actually like 45 minutes away from home. And I did move out for dental school. Like I was like 5 minutes away from the dental school, but I wanted somewhere close by. Tuition in Texas is also really cheap. I think all 3 universities in Texas are in like the top 5 cheapest programs in the US. And they're also all 3 like very good programs. So, don't let the tuition dictate where you go. But I would say like the biggest thing for me is the location, which is like convenient. Honestly, I didn't plan on moving to Chicago. I came here for residency and I decided to stay. I meant to stay in Texas. There's no state income tax there. So Chicago is like the opposite. But so that's a little bit. Apply to the programs you want to get into and then kind of go from there. Like don't worry about the tuition too much. Let that come a little later on when they send out your acceptance letters and then you can decide like, okay, is the tuition worth it or should I go to like this other program? So early on, like apply to the ones you really want to go to. Don't worry too much.
Yes, the next question is going off of that tuition. How have you handled dental school debt? And for your residency training, do you get paid?
Okay, good. Yeah, extremely good questions. You guys are thinking about the right things before you've even started, which is perfect. You guys want to start this early. So I'm very lucky. I don't have any school loans at all. I'm extremely lucky. Mom helped me out a lot and very blessed. It's definitely not the norm. A lot of times dentists will graduate with like 150,000 to 300,000 plus in loans, and it depends on what programs you go to. Some dental schools are like $80,000 a year, and so residency. There are some prosthodontic residencies that pay you. I think there's only like 3 though, and one's like UCLA, and I can't remember the other ones, but they pay about I think like 56,000. I think something like that. It's very similar to like a medical residency. My program did not pay. When I was there, it was the #1 surgical prosthodontic program in the US. So I was completely fine paying. And my tuition was around 40,000 a year and for residency. And there were definitely co-residents that had 7 digits in loans. And it was due to going to Ivy League schools like Harvard or Penn State for like for undergrad, like for pre-dental school and also for dental school. And that ends up being like 80,000 for over 8 years. So that's already like 720,000. And then you have compounding interest and you have like a lot more from residency. So, even then I think it's still worth it. So I would not, obviously you have to have a game plan. You got to try to minimize the loans you take, and you got to have a game plan for once you graduate too on how to pay that back. My personal experience and from my group of friends in dentistry, seems like it's very doable to pay that off rather quickly if you make certain choices when it comes to either practice ownership or working in a high production office. Don't let the loans bother you too much. I know it seems like a lot. You have to be conscious about the numbers and everything, but I think it's very good to get into like some groups now that involve dental financing. When I say dental financing, but I just mean there's like groups on Facebook like White Coat Investors, and there's a bunch of other ones, but a lot of people do end up with loans in the healthcare field. And so you're not alone when it comes to that. And there's a lot of people out there that can help you with it. So I think, was there a second part of this question? Sorry, I'm like rambling.
The second part was, do you get paid for your prosthodontic residency?
Oh, yeah, for the residency. So, yeah, so I think that's it.
So the next question is, what makes for a good veneer candidate?
Oh, a good what? Candidate?
Veneer, yeah.
Oh, a good veneer candidate. The ideal veneer candidate would be somebody that needs very minimal reduction. So anytime we do veneers, I do it in a way that's as conservative as possible. I actually will do a mock-up version of the teeth before we do any kind of grinding. So if a lot of times with veneers, we want to move the teeth, we usually want to show more of the teeth because a lot of patients over time, they wear their teeth down and they become flatter. So you want to kind of restore that with additional height. So we bring the teeth down and we also bring the teeth forward a little bit. And when it comes to back teeth, we actually bring them out. So we actually kind of like make the smile look even wider than it is. So the ideal patient would be somebody that needs longer teeth that need to come out and that also need to be built out this direction too. Because when we do the mock-up, we do like a wax version of the future teeth, and then we'll actually apply that into the mouth with a temporary set of teeth. And so the patient can actually see how they look before we start the case. And then if they like it, we'll actually reduce through the temporary material 0.5 millimeter or 0.3 millimeters. It depends on what material we're going to use for the final veneers. So we're actually grinding through the temporary material because we know where the final veneers will be, and we only have to reduce 0.3 to 0.5 millimeters for the final veneer thickness. So sometimes we don't even touch the tooth surface after that reduction. You got to be careful, like when it comes to veneers, you don't want to just grind straight through the teeth 0.3 to 0.5 millimeters, because then your veneers are actually thicker than they should be. And which is fine for the veneers, but it's actually like you're reducing a lot of natural healthy tooth structure when you really do want that enamel there for the bonding. Because if you actually go past the enamel, the outer layer of the teeth, the bond strength goes down drastically when you go into the dentin. And then at that point, I would actually recommend a crown instead. Some other things that, patients, they of course need to be comfortable financially, because the veneers can be, they're not cheap necessarily. It's a cosmetic procedure. Ideally, the patient doesn't brux or clench or grind their teeth at nighttime, but if they do, we have to restore them in a way that's predictable so that the functionality will be even between the top and bottom teeth. And there's a lot of detail that goes into that for prosthodontics. So, and the patients have to wear a night guard. Ideally, the patient doesn't work in a career like football or something where they could potentially get hit in the face. So there's a lot of kind of things to look out for, and you kind of have to tell the patients exactly what they're getting into, because once they do veneers, a lot of times they have to stick with veneers the rest of their lives. And if the veneers end up coming off at some point, they'll have to get a new set. And the bonding protocols that we do nowadays make it extremely difficult to come off, and they're actually harder. I would rather take off a crown. I'd rather take off 5 crowns than take off 1 veneer, because of how difficult the bonding is to remove. I literally have to grind the entire veneer off. Whereas a crown, you can make like little slits and you can actually fracture the crown off. The bonding protocols for veneers is ridiculous to remove. So yeah, I think that hopefully that answers like some of your questions.
The next question that we have is, what would you say is the biggest difference between prosthodontist and what a general dentist does?
So prosthodontics, the main things that we focus on involve diagnostics, and also of course like the actual application of the procedures. When it comes to prosthodontics, we're not looking at individual teeth. It's kind of a step back approach where we look at the whole case. Let's say that a patient's like breaking a tooth every now and then, and the patient doesn't know why, and like the previous dentist was doing everything exactly right for those individual teeth. Then prosthodontists come in, we look at the overall approach as to what is actually causing these issues. For instance, if the patient's like really grinding their teeth, is it because they have something called, well, it's like occlusal trauma, like there's a single point of contact that they're hitting too hard and it makes them want to grind their teeth? Or does the patient also have sleep apnea and they actually snore? And so when you snore, you want to clench your teeth together and kind of flex the muscles in your neck, because that actually opens up the airway. So a lot of times we'll take a look at cases from an overall approach and see whether or not there needs to be some sort of additional intervention and planning that's involved with the case. So once again, we don't really look at individual teeth. We look at like the overall picture. A lot of times we get sent cases from general dentists that are too complex for those particular providers. So let's say a case that needs like 24 crowns, like a ton of crowns, because the teeth are very small and they need to make them taller. That's called increasing occlusal vertical dimension, which is a lot of times given to prosthodontists to do. A lot of implant cases nowadays are training in prosthodontics involve like the bigger implant stuff. So you can get this kind of training as a general dentist. It does require a lot of additional training. And I would say the approach as a whole, like from a specialist point of view versus like an advanced general dentist, is definitely completely different. And the other thing is that when it comes to prosthodontics, we're heavily focused on literature. So when it comes to like knowing what kind of procedures are going to work in certain situations, and the predictability and the approach and the biomaterials, everything else is like heavily focused on in residency. So I was reading like 30 articles, probably like once every 2 weeks, like for all of residency, and it went into like a ton of detail. So it's a very hands-on approach too. We of course do a lot of cases, but I would say a heavy focus on how to make the case go well, and also predictability.
I think that's all the time we have for questions. So thank you for answering all of those.
No problem.
Thank you again, Dr. Prompton, for your presentation. It was really insightful and I really enjoyed viewing it. And thank you guys for joining today on today's live stream. The quiz will be posted on 3 places: the YouTube chat, also our Linktree, and on the GroupMe. Thank you so much for joining us, everyone, and make sure you tune in for tomorrow's session.